And so spinal fusion, when we fuse a spine, the whole goal is to hold it still while the bone heals. Now, for one level, that's relatively straightforward, but when you're doing a complex fusion, if this doesn't heal properly, you have a complete disaster on your hands. So anything you can do with hydroxyapatite carriers that can modulate or deliver biologics to enhance a fusion in a high-risk patient is a tremendous benefit for that patient, because these surgeries are high-risk surgeries for the surgery to fail and not to heal, and a non-union is a complete disaster in this setting. So this is something that has an immediate and direct applicability for biologics. Right now in the United States, BMP2 infused Medtronics, it's a $2 million US per day are spent on this product just for spinal fusions. And that's one product. There's a tremendous clinical need to deliver these products. The BMP2 doesn't even have a good carrier. It's in a collagen sponge. It's FDA approved to use anteriorly intervertebral. If you can get a hydroxyapatite carrier or rigid, it tremendously changes the way it can be used. The other issue is antibiotic delivery. In the setting of all these things, the other big nightmare for us is infections. Postoperative infections are just a total disaster, and it's a major, major issue for reconstructive orthopedics. Right now, we have this technology we're working on. We don't. Enyo has a technology, which he's letting us use, to deliver antibiotics and target away with these nanoparticles. And that's tremendously important, because the ultimate goal would be possibly to then cap these silicon particles to implants, and then you can develop implants where you can perhaps turn on or turn off antibiotic delivery, turn on or turn off osteointegrative factors, and revolutionize the way that we treat these diseases. And this, unfortunately, I'm out of time, so I don't have time to go over it, but right now we're able to do with these silicone capping is have controlled release of these antibiotics over time in a very efficacious way that can be modulated on the way that these particles are capped. And that then allows eventually, through the tunability of these, to release antibiotics, but not just antibiotics, any kind of protein. So bone morphogenic proteins, perhaps antibodies which could bind to particular cytokines and modulate an injury cascade. So if you have the ability to put a deposit of these particles in an area, say spinal cord trauma, and then modulate the temporal release of those particles to modulate a characterized secondary injury cascade, you can revolutionize the treatment of spinal cord trauma. And I think I'm out of time, so I'll just go through these things quickly. And I think in summary, there's been a lot of work. If you're a mouse, you're really living in a wonderful world, because we've cured a lot of diseases in mice. We can cut mice's spinal cords in half and make them walk again. And Daryl Jackson made this quote, we're doing great things for mice, but none of these things have been done in humans yet. That hasn't been translated yet. And I think the real goal is going to be to move out of the mouse and move into clinical trials and translational research. And I think the technology that we've been talking about these past few days really show a lot of promise, and particularly musculoskeletal disease. I think that leap could happen a lot sooner than some people realize. Thank you.
Time for some questions. Please.
Thank you. Thank you.
So in one of your early slides, you said that maybe there's too much NGF around, or this is causing chronic pain. And could you simply just deliver an anti-NGF, perhaps for a sustained period of time? Like, is that hypothesis, have you tested that hypothesis?
It's a theory. It hasn't been well shown. It was a paper by, I believe, Penn et al. In Spine, I think 2006, which was, the idea is when the disc is injured, such as an annular tear or fracture, the body tries to repair it. But because the disc has such poor blood flow, the reparative process doesn't work. So you get a vascularized ingrowth of granulation tissue, and then it doesn't heal completely. And then wherever blood goes, usually then the nerves follow, in general, and specifically the mast cells secrete nerve growth factor, and you get this abnormal innervation of the disc. There's thoughts about that. One idea would be, to what degree is pain relief from vertebroplasties or fusions from ablating that nerve? And there is people thinking about it as a way to target that nerve and ablate it. It's still controversial that is truly the pain generator. And the other issue is, once these discs get innervated and sensitized, there are so many nerves wrapped around all the joints. So the answer is yes, people are working on it, but by no means is it a solved problem.
So coming from the oncology world, I mean, one of the things that my colleagues used to say was that everything looks good in mice, right? Which is true, because they're inbred, whereas we're outbred. And so the component that I think is missing for translation, at least in part, is specific proteomic information, and then some understanding on a modeling level of what the particular proteomic information actually indicates and what an appropriate intervention would be. So,
Yeah, and that was so exciting to me hearing all these talks. Was almost everything I heard today lent itself directly towards that, either protein characterization or targeted delivery, or targeted delivery with the ability to modify it temporally. And that doesn't exist right now, and I think that could really revolutionize the way we do these diseases once we understand better the characteristics of the milieu of the proteomics of the disease.